All right, well, good afternoon if you're on the East Coast. Welcome to the National Minority Quality Forum's Friday webinar. We've had a very eventful week here, not only in America, but around the world. And so I just wanted to take a moment to reflect on that. And then and as always, I'm just gonna pass it to the microphone or the platform over to Ms. Keys, who always does a good job in ushering us through these conversations. We're talking about the All of Us research program and sort of not to piggyback back off, but related to our topic on clinical trials a couple of weeks ago. So with that, Mia, I'll turn it over to you.
Thank you so much, Brandon. And as usual, thank you so much to the NMQF family for just holding these really critical conversations. You know, as I was thinking about today's conversation, I couldn't help but to, of course, think about it in relationship to the times, you know, and you said it, Brandon, that, you know, this moment does call for reflection. It does call for work, whatever your work is, wherever your work is. And I really look forward to also looping in the significance of science with respect to social justice, and then also just making sure that we understand that whatever work we do, whatever work we bring, that is our, in you know, for lack of a better term, our protest. And so I'm very excited today to share the platform with Justin Henches, who joins us from the All of Us research program, where he serves as the acting chief engagement officer, as well as the research and financial chief financial and management officer. I want to make sure I get that right. So I really look forward to him unpacking what all of those mean in terms of experiences and what that brings to the table. But just to really ground you in the conversation, we're talking about the All of Us research program, which is out of the National Institutes of Health. It's overall a part of an effort to just advance healthcare, individualized healthcare, by enhancing enrollment of peoples into clinical trials with a specific emphasis on historically marginalized and minoritized and underrepresented persons in clinical trials. And so without further ado, I want to hand it over to Justin, who's going to give us a fantastic presentation. And then we're going to have some engaging questions, so stay tuned. Justin, welcome.
All right, thanks, Mia. I really appreciate being here. Let me share my screen here real quick. Sorry. Make sure, can you see that?
We can Hopefully. See you, Justin. Yes, we can see you.
Okay, perfect. So again, thank you, Mia, and thank you to the National Minority Quality Forum for hosting this webinar and providing me the opportunity to connect with you all about the All of Us research program. Before I start, though, I do also want to acknowledge what's happening in our country, and particularly in our communities of color. COVID-19 has had a disproportionate effect on communities of color. It's another painful example of the disparities in healthcare access and treatment that these communities face on a regular basis. For those of you that have been impacted, have had family members impacted by this disease, my heart goes out to you. I also think it's important to talk about the tragic deaths of Tony McDade, Ahmaud Arbery, Breonna Taylor, and George Floyd, among too many others. Has once again shown us the ongoing racism impacting our nation and our communities. Our program, and I personally stand with Black communities and all communities of color across the country in confronting this racism, this bias, and this injustice. I want to start today just recognizing that some of you may be tuning in who aren't familiar with the All of Us research program. And so I just have a few slides to go through just to give you background, and looking forward to the conversation. All of Us is an effort spearheaded by the National Institutes of Health and is the cornerstone of the Precision Medicine Initiative launched in January of 2015. All of Us is working to bring together 1 million or more volunteers from across the United States to donate health information for research. Among many other things, we're hoping that researchers may be able to use this information that we've collected and that participants have so generously provided, so that we can, to look at the steps we can take to stay healthy, to find health conditions early when they are most often treatable, to better understand and react to and solve disparities in our communities, and also to develop more effective, personalized, and precise treatments that are based on us as unique individuals. Our mission is simple but bold: to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. We aim to create a new model of research based on building and maintaining relationships with participants for decades. We want to deliver a valuable, rich resource and repository of data that will be accessible and safe. And finally, we will do what it takes to catalyze a robust ecosystem of researchers to use this national resource. Now, over the past 3 years, we've been focused on our participants, ensuring we are enrolling and retaining participants from diverse backgrounds. We have also been working on getting the data out to researchers via our public data browser that was launched last year, and the researcher workbench, which just launched its beta phase on May 26th. Now, while we continue to work on these objectives, we must now turn our attention to the researcher ecosystem. In particular, we must ensure that researchers from underrepresented communities can utilize the program's resources. This is a national resource, and it's important that everybody can have access to it and use this data to find cures. Many of you have already shared ideas with us about how we can help level the playing field by increasing the pipeline of diverse researchers and increasing capacity at institutions that have diverse researchers. Now, over the next few months, we'll be seeking out more ideas, and we'll be developing, in consultation with you all and others, a plan to catalyze this ecosystem. I do want to spend a few minutes talking about the ways that all of us is unique. Now, all of us is founded with the core values that participation is open to all, that the rich diversity of the United States is one of our greatest strengths, and that the participants walk with us as our partners. Participant input is welcome on every aspect of this program. Participants will also have access to the data they share and information about all of the research projects that use all of us data. All of us welcomes participants of all backgrounds and walks of life from all regions of the country, whether they are sick or healthy. And importantly, we want to make sure that we include those people who haven't taken part in or who have been left out of health research before. We're also building one of the largest health databases of its kind, which will include many types of data from surveys to electronic health records to biospecimens. We plan to make this resource as accessible as possible while still ensuring that we're protecting the privacy of our participants. Now, where we are as of right now, or as of, I guess, June 3rd, is that we have more than 350,000 people have enrolled in the program, with a little over 271,000 completing all the initial steps of the program's protocol. You can see we have a range of diversity, with just over 80% of our participants self-identifying as belonging to one or more communities that have been historically underrepresented in biomedical research. Now, we started 2020 with a list of priorities for the year. We wanted to enroll and retain our participants, and including a focus on our long-term retention strategies. We were going to begin implementing the beginning of our genomics return to participants with return of ancestry and traits. We were going to open the researcher workbench to beta testing, and we were going to launch our first major campaign, our mental health campaign. And then, of course, in March, COVID hit. And so in March 18th, we paused all in-person enrollment and other events for the program. People can still join. They can still find out information on joinallofus.org. But at this point, all of our in-person events are on hold actually now until July 13th. We're extending it past the 4th of July holiday. And we're working with our sites, both our enrollment sites as well as our engagement sites and other partners, to develop a plan to safely restart in-person activities. But we're not discouraged as a program. We've redoubled our efforts in retention. We think this is a really great opportunity to try new areas and new things to retain participants. In addition, and I know we're going to talk about this in a little bit, we've added activities to generate data to contribute to the COVID-19 research effort. We have had to slow down some of our activities around genotyping and the return of ancestry and traits. At this point in time, we've gotten that back on track, we think, and we're now looking at starting the return of information to participants in the latter part of 2020. We had hoped to do it this summer, but we needed to postpone it just a little bit. And we had to adjust our larger mental health campaign. We've postponed that, but we've added many of the things we were doing in that mental health campaign into our COVID-19 response. I hope this was a helpful overview of the program. We have multiple ways to find out more, from Facebook, Instagram, to our website. I look forward to the discussion, and again, thank you for the opportunity to join this webinar and talk about all of us.
Justin, thank you so much for that presentation. And then also thank you so much for framing and beginning your presentation on a note of solidarity. I mean, it's really, as a woman who is Black and an American, and who is fairly young presenting in spaces that are predominated by men who are white and who are older, especially in the sciences, it is really affirming to hear where you stand, and also that it is something that you take with you into the spaces where you enter. And I really imagine, and I don't wish to presume that everyone on the line feels exactly the same way, but I will say on behalf of everyone who's listening, thank you so much for your candor, and also for calling out those names of those who are now amongst our ancestors and fuel us in our work. So I want to throw a question foremost to the audience before I ask you some questions, given what you presented to us today. So, and this is a poll question. If you're not familiar with what we do with the poll questions will pop up on the screen, and if everyone can go ahead and answer it. How many of you have either heard of the All of Us program through NIH or participated in the program? Let's take a couple seconds to answer that. And of course, all of your answers are anonymous. And of course, as always, if you have any questions throughout this conversation, please post your questions in the question and answer chat, not in the overall chat, but in the question and answer chat, and we'll get to them. Okay, so it'll take a couple seconds for those statistics to come in from our program. But I wanted to know, Justin, so we often on the NMQF platform talk about health inequities, health disparities, and we talk about these issues, of course, from a community health perspective, a public health perspective, where we're not just talking about individual behaviors and causes for health outcomes, we're talking about communal prevalence of disease and so on and so forth. So in a nation with many health outcomes that are striated by race, and we're used to evaluating disparities from a community lens, what does it mean to actually leverage precise and individualized medicine?
Yeah, Mia, I think that's a great question, and I think there are a couple of different facets to this. You know, and let me just say, I've been at the NIH for a number of years now. I would not consider myself in the old category, but I also am fully myself when I say that. But
well
I think that, you know,
there you go.
yeah, well seasoned, yeah. We've, you know, since my time at NIH, we've consistently been talking about health disparities, and quite frankly, we need to do a better job of not just talking about it, but actually putting the resources and the time behind solving these problems, and helping communities to solve their problems, to solve these problems, right? I think that the way all of us can contribute is that we can take it from a community or population standpoint, where we can look at things like environmental factors, where we can look at things, you know, like, you know, what type of landscape people are living in a rural area, in an urban area. And we can combine that with information about the individual, so that researchers can not just say, well, if, you know, if somebody lives in this type of area, you know, this happens. We could also say, well, if somebody lives in this type of area, you know, they live in an urban area, we have, you know, and they have this type of, you know, background with their family, say, do this type of exercise or don't do this type of exercise, that can help us understand the community, but the individual as well. And I think the other thing I would say is that that this is complex. And I think the thing that I really appreciate about the program is that since its beginning, the program has wanted people that have not been represented in biomedical research to be at the table. You know, as a gay man, like, this is the first study that someone has asked me to be at the table and actually provide input. And so I think that will be a help as we continue to build the program.
Yes, I really appreciate you offering that. And I think that if Dr. Puckrin, Gary Puckrin, the CEO of NMQF, were on this webinar, he would completely agree with you. You know, we had him on, I guess, 3 weeks ago now, or 2 weeks, something like that. Time is really flying by. And he was really talking about the necessity to ground our conversations in equity, but really to also move the conversation along so that we are talking precision medicine, we are talking about outcomes and solutions-based science, such that precision medicine actually is. So before we go into another question, let's go back to the poll and find out who among us has either participated or heard of all of us. So most of us have either heard or participated. I'd love a sound off either in the chat of those who have actually participated. If you've participated, I don't think there's a hand raising function, but maybe you know, call yourself out in the chat. And also, you know, if you have reticence or questions about participating, you can mention that in the chat as well. So Justin, you were talking a little bit about what all of us is doing with respect to COVID-19 in terms of causes and treatment. So I'm wondering if you can talk to us a bit more about that, go into detail a bit more about what you all are doing to support research in that way. And then specifically with respect to the impact of the virus on African Americans and Hispanic and Latinx communities, can you tell us a bit more about that? And then while this isn't in the question, one thing that I'm now mindful of, because you did mention in terms of your sexual orientation, we don't yet have data on the ramifications of COVID-19 for members of the LGBTQ plus community, right? And that's problematic as well. So let's talk about all of that.
Yeah, no, those are all great questions. And I think, you know, I would say that, you know, we as a program, you know, in mid-March, you know, made some decisions to shift our priorities to help with the research around COVID-19, recognizing not only the specifics of the disease, but the impact of it, you know, across communities. And so the first thing we've done, and we're now, let's see, we're in June and we just launched our second survey. We're doing what we call our COPE survey, which is our COVID-19 participant experience survey. We've taken pieces of our mental health campaign that we were already going to do, and we've moved them forward and put them into this survey for our participants. One of the things that, sorry, Greg, I tend to move when I talk, so I'll try to stand still. One of the things that we're doing is we recognize that there's obviously the, you know, physical toll on the body from this disease, but there's also a mental health toll, right? There's a toll of we're stuck in our homes, or we are frontline workers that have to go out and, you know, be in the grocery stores, be in the you know, emergency rooms, be at hospitals. And so what we want to do is collect data and information about how people are coping with this. And we're going to be doing this monthly. This started in May, and we continue to make improvements on the survey as we go through. And our second one just launched in June, or just launched yesterday. We're also looking at what can we collect through electronic health records of participants that are already enrolled related to COVID-19. We know that we can get some data that this is a field that is now in many electronic health records. We can get data that we think can help researchers, you know, look at comorbidity, look at when the disease may have first popped up in an area. We think that this can be really helpful. And then we're also working with the CDC and others to better understand when and where COVID-19 arrived in the United States. So for those folks that had enrolled in the program and provided a blood sample before March, when we paused in-person enrollment, we're going back and we're going to be doing serology testing on those samples. And the thing here is besides just doing the testing to try to find out from our stance when we think this may have entered the country and where, we're also going to be providing this research and these results back to our participants. And so we think that will be helpful for them as well. So those are some of the things we've started now. I think we are still looking at what we can do in additional areas. And in particular, I think, we recognize very clearly that there is not a good amount of data on, how on African American communities, on Latinx communities, on sexual and gender minority communities, and we think that our resource, because of the diversity we already have, we think that this can be a really helpful resource to get that data out there so that we can make decisions about how best to combat this disease.
Yeah, it really sounds in a lot of ways that that through all of us, there really is a quickening, a hastening of recognition that these demographic data are critical to the science, right? And so I'm really glad that in so many ways it's a precursor for how other agencies, and even on the local level, public health departments, and then also more specifically hospitals that do use EHRs, electronic health records, can really leverage all of that. I do want to just share with everyone, in case you don't yet know, and I'm going to put Keiko on the spot to see if she can find a link to provide you all. But HHS just announced yesterday that they are absolutely requiring ramped up collection of demographic data for all of its diagnostic laboratories, and also training with respect to public health departments to collect these data and for these data to be shared with public health departments. The announcement just came out yesterday. It's a big thing, especially under this administration. I think that's imperative, and those data requirements are with respect to race and ethnicity, to gender or identity, to sexual orientation, I believe, to language, both preferred spoken and written. And so please look into that so that you all are familiar with that. I'm talking to you, audience. We do have a question, and it looks like, Brandon, thank you so much for finding that. So you all can find, that is correct, Brandon. Yes, thank you. So I'm wondering if you can talk to us a little bit about the national to local partnership, with respect to generating data, but then also just generating advocates and new persons to be involved in all of us. What's the outreach look like? Who are you partnering with on the grounds to get more representative allies within the clinical space for all of us?
Yeah, no, that's a great question, Ian. And I think, let me start with this, that this is built on trust. We can't do anything with this program unless we have the trust of our participants and the trust of our communities that we're working with. And that means we have to be in it for the long haul. This can't be we pop down at a health fair, say, hey, give us some data, and then you never see us again, right? There have been, research programs that have done that, and that's not fair to participants. And so the first thing is what we are working on, and what we've been working on for the last number of years, is setting up, partnerships and working with people to build trust in communities. We have a series of partnerships at the national level. So we have a partnership with our sister institution and the National Institutes of Health, the National Library of Medicine, that works with libraries across the country to help educate folks about what medical research is, why it's important that we have medical research. They help educate about what all of us is, but really that focus for me is, let's just start having the conversation about why medical research is important, and acknowledging, quite frankly, the sins of the past in medical research. We can't go into a community and talk to someone about joining this program without understanding the things that medical research has done to communities that was wrong. And so I think that's one of the main kind of just having that honest conversation. We also have national partners. We have a couple of different types. We have a number of national partners that work with us to set national strategy, but also work into the community. So this is like the National Alliance for Hispanic Health, the Delta Foundation, the Asian Health Coalition, Stanford PrideNet, and 50 Forward in Nashville. And those help us both set, help us work with communities in specific areas, specific demographic areas, as well as then locally they reach out and have partnerships around the country. We also have what's called our community provider, Kim is going to be really mad at me that I just forgot what the acronym stands for. It's our CPGI network. And those are groups that are across the nation. Some are national, some are local, where we've partnered to help do education about what All of Us is. Thank you, Natalie. Yeah, Community Provider Gateway Initiative, where they can help us, make connections within communities. All of our sites, so our regional medical centers, or our DV, what we call our direct volunteer program, they all work with our partners, as well as having their own connections to the community. I think for us, it's really important, again, not to just say sign up for All of Us, but to actually go and talk to people, understand why, why people are reticent to participate in medical research, why they may be scared to do so or angry to do so. And if somebody doesn't want to participate, if we can just have a conversation about why research is important, I think that's a benefit to everybody.
So I want to continue along that strain there. In the wake of COVID-19, there will clearly be clinical trials that will have to take place to test for viable vaccines, right? Mm-hmm. Given what you just acknowledged, that there are communities that historically do mistrust the just largely medical institutions, what sort of messaging does does All of Us plan on putting out that might really help to bring people into the fold of medical settings, of clinical care settings, or does All of Us have any plans to work specifically with healthcare settings to strengthen their outreach?
Mm-hmm. So, we work with our current partners quite a bit. So all of our regional medical centers and other sites. And we do a number of different educational events. PrideNet through Stanford has developed an amazing cultural sensitivity training when working with sexual and gender minority populations. And that's something that we've seen a very positive feedback from the sites that we work with. That are part of our program, and we're working with our other partners to develop similar trainings. And it's a conversation starter. Of course, you can't have a 1-hour training and then all the problems are solved. But we think that we can do this and provide a conversation starter. And we go back to our values. Our biggest one of our biggest values is that this program is open to all people, and that we value diversity because that's our biggest strength in this country. And I think that's something that, for us, we've been able to have that conversation. And I can't, I'm not able to know how NIH is going to have these conversations as they, roll out any of the clinical trials. I would encourage those clinical trials to do the same thing, to recognize the past, to talk about why, this is important, and then to listen. I think that's one of the biggest keys here, is that you have to listen to people, and you have to help, you have to understand where people are coming from, and you have to meet them there. We do a lot of work of going into, right now we're paused from in-person events, but we're still trying to do this digitally, is going in and meeting communities where they are. And, instead of, there can be sometimes a sense of, well, I'm going to sit in DC or in Bethesda and just say, hey, everybody should do this. That doesn't work. because this is personal for folks. Giving your medical information to somebody is personal, right? Getting a vaccine, trying to do that is a very personal decision. I think we need to meet people where they are.
Yeah, I really appreciate you mentioning just how personal it is to this moment requires all of us to be. I think during your presentation, you were talking just a little bit about privacy concerns and everything with respect to data collection, especially as our modes of listening become more and more virtual, right? So I'm wondering if you can go a bit more into what that landscape now looks like, well, rather you all use the terminology ecosystem, which I really appreciate. Can you tell us more about what that looks like in terms of using the data and sharing data and everything like that?
Yeah, so that's so I mean, here, let me start with saying that the program, we started enrolling nationally in 2018, and one of the things that we wanted to do was we didn't want to enroll people for 10 years and not have any data coming out. We want to make this resource available to people and researchers as quickly as possible. So we started last year with our public data browser. The public data browser has aggregate data. It doesn't get into a lot of detail from a vantage point of, you're not able to drill down as a researcher to get to, a lot of specifics, but it does give value because you can see how many folks have signed up. You can see, the type of diseases that we're seeing in their electronic health records. And you can do some of this, anybody could come in and do a little bit of research to try to understand what the cohort looks like, what our participant group looks like. We launched we launched the researcher workbench in beta phase just last week. Yeah, last week. And that right now we have it's limited who can get into it. It's limited. You have to have what we call an ERA Commons account. So you have to have you have to be known to us at the NIH, and your institution has to sign off on your access to it. This is a way for us to test out the researcher workbench with known individuals, so that if we can get really good feedback from them, but we can also then know who's in there and who's accessing more data. And one of the things we do is we're very conscientious of making sure that it is very difficult to re-identify a participant based on the data. And so right now we don't have any genomics data in the workbench, but as we do our genomics process, that data will be included, and so we'll have what's called a controlled tier, which means you have to go through even more scrutiny before you're able to access that data. The other piece here is that we have a requirement under the Cures Act, which was passed in 2016, which provides us with our authorization. It's actually a great requirement. We're very happy it's in the law, but we would have done it anyway, which is that we have to publish or put out publicly the researchers that are accessing the data in the researcher workbench and the type of research they're doing. And I think that will be, transparent. That'll help, the community police itself when it comes to, making sure folks are using the data in the right ways. And we have put more stringent requirements on our security and our privacy than I think we're required to, because we really do want to make sure that this information is used for the right purposes, that participant information is safeguarded. And so we take this very seriously.
Yeah, I just had to write that down. So you called it the research and workbench. That's the data repository, that's the name of it?
Yeah, so the researcher workbench is how folks can get into the big database. And right now what it does is it provides you to, if you're in it, you're able to do what we call the cohort builder. So you could say, I want to see how many people are in this database, in the database that are, white 40-something-year-old gay men that live in DC. And depending on the criteria, you would get a number to be able to say, oh, well, and maybe you want to look at the incidence of diabetes in a certain area. How many participants have that? So you can basically build a cohort And then from there, we have a number of tools that you could actually do, analysis on, use to do analysis on the data. And right now, that's it's Jupyter notebooks, and it's Python, and I'm forgetting the other coding language. R
is there? Okay, good.
Yeah, and again, this is our beta, so we're started with that. We recognize that not everybody knows R or Python coding. We hope, because of the way science is done now within teams, that most teams hopefully have somebody that can do that type of coding. But we're also working on bringing other tools in, so others, more simplified statistical tools, and other tools that we can build out as this process goes on. So
how do researchers secure an ERA Commons account?
That's a great question. I have to look into the specifics. It's not something that all of us control right now. It's done through the NIH, but I can definitely get specifics on how to do that and get that back to you. Our goal is to move past that, right? This is the first step. We want to make sure that we can use to get to an identity proofing tool that we can use so more people can have access. So.
No, that makes perfect sense. So I think any follow-ups can be given to Brandon, and he would be sure to get that out to the audience. Justin, I want to go back to something you were talking about briefly, and excuse the sirens. They're likely peaceful protesters about. So anyhow, so you were talking earlier in your presentation about the three prongs of the all of us ecosystem, right? And if you can talk specifically, you can give us another overview of what those legs of the triad are, and then especially talk to us about the last one, because I think people have questions about workforce and pipeline and how researchers can become a part of all of us, especially researchers of color.
Yeah. So our three legs of the stool are our participants, so enrolling and retaining 1 million or more diverse participants. The database, so getting the robust and multifaceted data available. And then the third is catalyzing the ecosystem. And here I think I think this is the place where this is our new frontier, our new challenge as a program. One of the things I would say is that, one of our core values is that data will be accessed broadly for research purposes. And so this means that we want to make sure that folks, wherever they're sitting, whether they're sitting at, a Harvard or a Stanford, they're sitting at a Howard University, or they're, sitting at a Chippewa Valley Tech in Wisconsin, that if we have researchers that have really good ideas, they should be able to get in and access this data. Well, it's not just, we can provide the access, but then we also have to make sure we're providing the tools, right? We have to make sure that folks are able to, when they get in to see the data, they actually can use it, and they have the tools and the background to be able to do this. So what I'm really interested in is trying to figure out what's the best way for our program to help that. We're interested in, is it, just some ideas we've thrown out and we're starting to think about here, is it almost, we do small awards to researchers so that they can learn Jupyter or learn R, or they can, go and do like an internship almost at our data and research coordinating center to learn how the program works, to learn, how to use this data. Anything from that to, do we do institutional awards so that we bring more institutions in that can bring cohorts of people? And I think this is something that we've received feedback over the last couple of years. We haven't, because we've been focused on leg 1 and leg 2. We're now turning our focus to this, and I think that I would be really interested in hearing what folks think from this group. That would be the area we could make the most impact, and we could do the most help to raise the playing field or level the playing field by raising folks up.
So that's great. And I want to challenge everyone to really take you up on what you're saying. If you do have ideas of how all of us can really help to improve the pipeline, the research pipeline, drop those comments in the chat box, or also be directly in touch with Justin. You can get his Justin, what's your email?
So it's my first and last name, so justin.henches@nih.gov. And I think if I can figure out the technology, I can just type it in there as well.
Sure. Yeah, definitely be in touch with him. As someone who is super nerdy and into coding language, it is a great tool to know how to leverage. I'm more familiar with R compared to Python and others, but that's on the list as well of things to do. And you're in sheltering in place, and I don't, forget what you heard about summer opening and being available to you. You're going to be home, so you might as well learn a coding language. I want to raise a question that someone else brought up about the impact of new and really exciting technologies and research and things like that, and treatment that comes from the advances in technology and research, but also affordability and access. What will that look like in this new frontier that you're describing? Not to put you on the spot. That is not a question that only you can answer, right? But it is,
Yeah.
Mm-hmm.
It's a great question. And it's, our program can't solve that, but I think our program can help show a way that we can change at least the way medical research is done, where we can show a way where participants are partners, where data is available, that it's not sitting behind, in the old, it's not in somebody's file cabinet someplace, it's out and available so more people can use it. And that we allow researchers, whether they be PhDs with 30 years of experience, or the community college teacher who wants his or her students to do a quick science project, right? I think if we can show that works, I think that will help change the way research is done. And I guess then my hope, and it may be naive, but that would be able to help with the other things, with the affordability of these drugs and the affordability of technologies that are used to help people. I think that I hope, I guess.
I also hope, and I hold on to hope, and I also hold on to concerted action. And so I'm getting my doctorate in public health at the George Washington University Milken School. And one of the things that we always talk about in class has to do with just historically difficulties that especially marginalized and minoritized researchers have had with gaining access to NIH grants. It's already quite difficult, right? Irrespective of one's background, it's difficult, but people of color have really experienced hardships with respect to gaining access to grants, access to just different funding streams. And a lot of it has to do with the very point that you're making, which is representativeness at the table, right? So whether that table is the bench, the lab bench, or the actual decision-making bodies where certain grants are mentioned. So not that you have to speak to who sits at those tables, that's not what I'm asking you. I want to know, how can researchers really start to leverage, or not start, how can researchers in that, of that ilk really leverage what NIH has to offer?
Mm-hmm. Well, again, I don't want to speak for all of NIH,
sure.
Because,
but you mentioned, for instance, the different grants for coding and things like that.
Right. And I think that's where our program, has a unique opportunity here. I think that there is, you know, we have been, our program has been built in, quite frankly, in record time using methods that the government has not traditionally used, and doing things a little bit different, because we recognize that's how we had to do it to get where we are. And I think this is a place where we could, you know, where we could do that again, where we could, you know, do, you know, small awards, you know, to folks to help them with trainings, you know, to learn coding. We could do, you know, we could set up buddy programs, for example. We could, you know, we can, and I want to work with the institutions that, you know, have traditionally or historically not been at the table, because I think they have to be at the table. And you know, there was a study, and it came out, I think it was 2 weeks ago, maybe 3, that talked about, you know, underrepresented, in particular, researchers of color and women researchers who had, if I'm remembering correctly, who their ideas were the most diverse or most kind of, you know, unique ideas. They were pushing the science forward, and yet they were not getting the tenure track positions. They were not advancing in their careers as much as the minority or the majority, you know, white male group. And I think that that's something that, you know, is incumbent, quite frankly, on people like me that are sitting at the table, white males, to say, wait a second, we've got some really good researchers here doing some really amazing research. Why aren't we promoting them? Why aren't we bringing them to the table? You know, I think that's something that is, you know, my responsibility to make sure that I help bring people to the table and help bring people into the research enterprise. And I think.
Oh, yes.
No, go ahead.
No, I was just going to say thank you so much for just the way that you framed that answer, right? Because it's one thing for a researcher of color or a sexual minority or a woman or intersection of all, you know, of those statuses to say to themselves, I've been doing the work, I've been putting in the time, I've been collaborative, I've been collegial and everything like that, yet my work is not rewarded in the way that is valued by the academy consistently, right?
Right.
But you're not saying the onus is on them. In fact, what you're saying is continue, you know, persons who are in those categories continue doing that work. The onus does fall on those who sit at the table to recognize the value that work brings, and therefore the conduit of that work, the embodiment is important. So. No, and I'm so glad that you said that.
Yeah, I mean, and you know, I have you know, again, as being a part of the SGM community, like, you know, there have been times where I've seen that, you know, for me, and for people in my community not be included at the table. But again, you know, I'll be, you know, we should be having this conversation anyway, but especially in the light of the events over the past number of weeks. You know, as a white male, like, I have a responsibility here. I've been able to enjoy the privilege that has been granted to me just on, you know, because of my birth, and I have a responsibility, I think, to help other people get to the table, to help other people, you know, just to help other people up, and I think it helps all of us. Not all of us, the program, but all of us.
Yes, but that was great.
Yeah, it helps everybody, you know, in the end, because you know, my life experience give me one set of ideas or one set of perspectives, and they may be right some of the time, but somebody else may have a different background and you put us together, and, you know, we can solve the problems of the world, right? But we have to bring people together to do that.
We have to bring people together, and people have to be willing to, as you said earlier, listen in a really deep way and value what new science has to say. You know, we can't have precision medicine without more precise data, and more precise data comes from diverse experience, right? So thank you for that. I want to go back and touch on the issue that you brought up around trust, and the issue that you brought up around historically different communities having longstanding mistrust in not just institutions, but also just in the scientific process. So can you, for those of us who may have heard of, who answered the poll question, but they were answering yes to have heard of, they heard about all of us, but maybe didn't participate. So can you walk us through literally what it looks like to sign up for All of Us? So I know there's a blood sample related, and help us to understand, or give us a sense of how people can work through their reticence step by step.
Mm-hmm. Yeah, so it is a step-by-step process, and like I said, when I was talking about the number of participants we have participants who have started the process, and there's some place in that process, and then we have participants that have completed what we call our core protocol. And some people get to a certain point and they're like, you know what, this is enough for me. This is what I want to contribute, and that is valuable. Being involved up to that, whatever point they decide is valuable. Because they're providing information that will be valuable in research. So basically, the easiest way is you can go online to joinallofus.org. You create an account. We have a consent form. It's a form, but it also is videos. So we walk people through what it means to sign up, what it means to consent to give data to this program. And then depending on where you are, you can be selected to give a blood, urine, and sample and physical measures. Of course, right now we've paused all of that in-person activity, but eventually we'll get back to that. And then you also have the opportunity to fill out a number of surveys. And so we have what we call the basics, which are a series of surveys just about you, about your family, about your lifestyle, that we think can be really helpful information for researchers. And then we have additional surveys as time goes on that you can fill out, including COPE, which again is related to mental health and COVID, that we think we can help. You also have the ability to share your Fitbit data. And if I'm remembering correctly, I think last month we launched, you can also share Apple Health Kit data. And so there are folks that want to do all of this, and that's great. There are folks that want to, consent and share, survey data, and I think that's great because, and there's folks that want to consent, share their electronic health records, and don't want, just don't want to hear from us again. And I think all of these pieces, are valuable. And I think that as people learn about the program, as they experience the program, I think that helps to build trust. And I think we have to communicate back to our participants, like, why are we using this? Why are we asking for information around your mental health and COVID? Like, what's the value? What's the value of this for research? And then we also just have to check in with our participants, and we have to be there for them. And that's one of the things I will say that I have been, particularly proud of our program in over the last, 3 months. That, as we paused in-person enrollment, we've had our frontline staff, our staff working at the clinics, at our sites, that are reaching out to participants to talk to them and just say, how are you doing right now? Like, if you don't want to fill out a survey, cool. How are you doing? Right? We want to check in with folks because in the end, the research is great, the data is great. We want to do that, but this is about people, and we have to be respectful of where people are.
There's high tech and then there's high touch, right? This is what it sounds like you all are doing, the high touch stuff as well. I'm really glad to hear that. Justin, can you remind everyone of the website?
Sure, it's joinallofus.org. And since I think I have been able to, I will put it in the chat as well for folks.
Great. That's that high tech there.
Yes, I am definitely not the high-tech person in our office, that's for sure.
Well, you bring your own set of skills, and then that's why we have collaborative teams, right? Exactly. So you mentioned earlier some of the regulations that the Cures Act set out for NIH with respect to, really quickly before I do that, is the website accessible in other languages outside of English?
Yeah, so right now the website is in English and Spanish. We are working through how we're going to translate other pieces of the program into other languages. We do have some, not the website, but we do have some other assets or other, flyers and that type of thing in a few other languages. This is one of the things that, we're committed to. It's a lot of work, and it's a good thing to do this work. And we want to make sure we get it right. So we are working on getting other languages out there.
Excellent. The consent documents as well.
Yeah. So the consent right now, again, is in English and Spanish, and we're working on how to facilitate that consent, through other languages.
Excellent. I'm sure we can take that question in so many directions, and given that we have 5 more minutes, I do want to make sure that on some level, Brandon, we come back to that. But I wanted to ask you a bit about, so you mentioned that the CARES Act laid out a lot of regulations for NIH in general, and of course that impacts all of us. What else is Congress doing that impacts how all of us can operate?
Well, I would say that Congress has been an amazing partner in this. I mean, they have shown their support. Obviously they've shown their support through giving us funding, and I am very thankful to them for that, especially in my CFO role. But they've also been our partners because they're interested in what we're doing. We brief the Hill on a regular basis about what we're doing, and how things are going. And many of the members have, been at our events. A number of members were at our national launch events 2 years ago. Other members go to local events and talk about the program. We've had folks tweet. We've had folks, do Facebook posts. And I know that there have been some members of Congress that have signed up because they've publicly said they've signed up. So I think we have a great partnership with Congress to get this program, to continue this program. I think they also value or understand the value of the diversity aspect of this, of the, making sure that folks that are underrepresented are included. That's one thing that I the bipartisan support has been really amazing and has been helpful as we've, navigated, how to get this program set up very quickly and to, get data out to people very quickly. And so it's been a great relationship.
I'm very glad to hear that, especially because we don't often hear just the good things or the things that are working working well in Congress, especially on a bipartisan level. But to your point, I think science really does bring people to the table in a way where shared interests are vivid. So we have 2 more minutes, Justin, and I'd like for you to please close by answering a question about value. You've been saying value and values throughout your presentation and in your comments, and I really appreciate it. I'm wondering if you can harken back to the core values of all of us, and tell us how is all of us actually embodying those values and demonstrating commitment to those values through action.
Yeah, that's a great question, and we have 8 core values, and I won't go through them all. I've kind of talked about many of them as we've been talking. They're on our websites, both the joinallofus.org website as well as our allofus.nih.gov website, because we have to have our .gov website as well. When we wrote down these values, roughly 4 years ago, I think, folks thought, well, it's good to have these and we're gonna follow them, and that's gonna be great. And I think what it has shown us is that it has been, but it's been hard. It's hard to take, a value where you talk about, data being accessed, broadly, but also that security and privacy are of the utmost importance. And we have to balance those two in every decision we make. I think what it has allowed us to do is to have a guidepost so that when we're making decisions, we regularly say, and And I've been lucky enough in my acting engagement role to be the one that can raise my hand and say, is this part of our values? How does this meet our values? But it's not just me, it's all of our folks in our program do this. And so when we talk about, the rich diversity of the United States, like we make sure that we are, when we're going out and talking about surveys or talking about getting information, we want to make sure that we're reflecting that value. So it's been really helpful to have those to build the program.
Yeah, Justin, I feel like I can listen and talk with you for much longer than we have time for, but I just want to say thank you for your time, for your energy, and for answering our questions. I again encourage all of you, if you're not yet, if you don't yet know if you're going to sign up, go ahead and at least read the information around all of us. And then if you have additional questions, feel free to be in touch with Justin and with anyone over at All of Us, or to ask questions of the NMQF family. Thank you, Justin Hinches, Chief Financial and Management Officer, as well as Acting Chief Engagement Officer at All of Us Research Program at the National Institutes of Health. And as always, I'm Mia Keys. I'm over at the American Medical Association Center for Health Equity, and I'm very glad to have spent time with you today. I turn it over to Brandon.
All right.
Thank you all.
And I'll be real quick, we're right at the 101 mark. So just thank you guys for participating and educating us. Mia, as always. Thank you, Justin, for letting us know more about the crucial work that you guys are doing at NIH. And it's right in line with what we always strive to do at the National Minority Quality Forum. So it's a good partnership, and I would like to wish you all have a very good day, a very thoughtful day, and just think through the times that we're having, and participate in the way you feel you can. With that, good afternoon, folks.